Hello, good afternoon. Thank you for joining me today at this session for the Royal College of Emergency Medicine ED Educators Conference. My name is Carl. I am a paediatric emergency medicine consultant in Derriford Hospital, Plymouth. Today I will be presenting work from my time as a paediatric emergency medicine consultant at North Middlesex, during which time I was also a mental health champion. This is a picture of me. I hope you're taking care of your own mental health today, perhaps with a cup of tea. So why did I undertake this work? Why did I want to introduce mental health scenarios into our simulation program? The answer is relatively simple. Across the country, and in particular in North Middlesex, we are all seeing increasing numbers of children come to our doors with mental health emergencies. Self-harm, overdose, absconding, running away, getting in trouble with the police. All of these issues are now occurring, perhaps I would suggest, on a weekly basis. Alongside surges in A&E attendances at large, our mental health services are squeezed. Kids with mental health distress are having long waits and longer queues. To meet this challenge, it is the responsibility of all of us, not simply the specialists. Traditional training has a bias towards physical health. Our workforce, our emergency workforce, in general terms, admits to having a poor understanding of the issues. We need to train up our non-specialist workforce, our emergency doctors and nurses, our paediatric doctors and nurses, our general practitioners. We need to all face this challenge together. I was personally influenced by my goddaughter, who at the young age of 8 sadly tried to hurt herself about 2 or 3 years ago now. I'm happy to say she's doing well at the moment. So what were my aims? My first aim was to achieve parity of esteem for mental health in our hospital with regards to our simulation program in the emergency department. This meant treating mental health cases with the same educational weight, giving it the same time, the same attention as we were giving our physical health emergencies such as sepsis, trauma or asthma. My second goal was to practically implement a series of mental health themed simulation scenarios on a regular basis inside our department as part of in situ simulation. That is to say, to complement our existing traditional physical health simulation sessions that we're running monthly, and not to be a one-off. It was to embed mental health into our routine simulation rhythm and culture. I also intended to make the training bespoke to the needs of our staff and bespoke to the cases and caseload that we were experiencing locally. As such, these were the 6 scenarios I chose. In order to set this up, there was 2 steps. The first was the teaching materials and the second was logistical matters. So in order to design a series of mental health scenarios, I spoke to experts such as Sam Jones in Leicester, James Dearden in Devon. I visited the CAMS team in Dorset. I visited the simulation team in Wolverhampton and created my own written materials as well as a series of accompanying videos. In order to have quality physical health simulation scenarios to go alongside this, I took these scenarios from the resource Academic Life in Emergency Medicine. So with the materials ready, set about getting staff availability, and we had a slot where staff time was protected every month on a Friday morning for mental health, and a different Friday for physical health. So we had one of each and every month. This is our department, and this is typically the corridor where we ran the simulation. Before and after each teaching session, I would gather confidence levels with respect to the simulation topic, and afterwards again gather experiences both in terms of confidence and in terms of just written feedback. So over a 12-month period, we had 84 participants across 10 mental health sessions and 106 participants across 12 APLS sessions. This slide shows that the confidence levels of staff increased much more following mental health scenario teaching than for traditional APLS teaching. The qualitative feedback from debrief and from the written feedback fell into 5 themes. The first was that a lot of people reported feeling that their communication improved, in particular between medical and nursing teams, and also with respect to managing a child in distress. In particular, there was a lot of comments about the benefits of understanding autism and neurodiversity. The second theme was that as a result of good psychological safety, they felt that the simulations were providing a safe space for practice. The third theme was that many felt the scenarios to be highly realistic, engaging, and that especially included emotional elements. Of course, as we've seen before, but it was also seen here, across both mental health and physical health scenarios, team and clinical confidence increased. Of course, the increase appears to be greater with those mental health scenarios. And then the last theme was that we were complimented on the structure of the teaching, the strong facilitation, and the time and attention given to debrief. These themes go some way to explaining why confidence improvements occurred. The teams felt engaged, the scenarios were novel and emotionally challenging, and they were supported by structured facilitation and structured reflection. So what does this mean for you listening? I strongly encourage you to consider your organizational commitment to culture change and parity of esteem for mental health. This is one step that goes towards that. Such a simulation program is low cost, and it doesn't need new infrastructure. It does need staff time, but when you ask staff their confidence levels at managing psychiatric emergencies, it's typically low, and it's time well spent. It requires faculty input, but if you think about it being once a month, that is not unsustainable. And you can make the scenarios bespoke to your circumstances, your population, your serious incidents, your violence and aggression rates, and make it matter for you. It was also especially interesting to see cross-disciplinary collaboration, and that was certainly an advantage, building bridges between specialties and departments. Limitations and future directions are shown here, namely the data is self-reported and tier 1. It would be very interesting to consider whether we could determine impact on patients as a future direction. In short, achieving parity of esteem for mental health in medical simulation is possible. I welcome your questions, and if you'd like further resources, see my YouTube channel or email me for PDF files of the mental health training.